In the next 10 minutes, I want to dive into the last guideline released for management of varicose veins in lower extremities. This guideline is recommended by several societies such as Vascular Surgery, American Venous Forum, American Vein and Lymphatic Society, and endorsed by the Society of Vascular Medicine and International Union of Phlebology and Society of Interventional Radiology. So, as a union agreement and great value of this clinical advice, our aim is to review first terminologies and recommendations provided in this guideline released recently on 2023. Hi, this is Dr.Aghdasi, interventional cardiologist and venous disease investigator. This part is not only beneficial for radiologists who are interested in vein disorders, but also is important for phlebologists and surgeons who want to intervene pathologies arise in venous territories. At the starting point, this guideline will discuss on the role of radiology and specifically duplex ultrasound scanning as the diagnostic choice for evaluating venous reflux. The definition for pathologic reflux time is defined as more than 1 second or 1000 milliseconds of flow reversal in common femoral, superficial femoral, or popliteal veins. For other veins, including superficial truncal veins, such as great saphenous vein, small saphenous vein, anterior and or posterior accessory saphenous veins, deep femoral, tibial, or perforating veins is pathologic if it is more than half second or 500 milliseconds. Let's go through the reason. The foropopliteal veins are the largest veins in the extremity, and it may take longer for the valves to close compared with valves in the superficial perforating and deep cuff veins. So 1 second for femoropopliteal reflux and half for other veins are accepted. There are 4 types of reflux: junctional reflux, axial reflux, segmental reflux, and perforating reflux. Junctional reflux is seen in saphenofemoral junction or saphenopopliteal junction. Axial reflux is a retrograde venous flow from the groin to the cuff and can be with or without junctional reflux. Axial reflux or the great saphenous vein is defined as the uninterrupted retrograde venous flow from the groin to the upper cuff. Axial reflux in the small saphenous vein is defined as the flow reversal from the knee to the ankle. And axial reflux in the anterior or posterior great accessory vein is retrograde flow between 2 segments at least 5 centimeters apart. Segmental reflux occurs in the superficial or deep veins and is a limited type of axial reflux. As an example, a reflux which is seen between 2 perforators that communicating deep to superficial vein is a segmental reflux. Perforating reflux is defined as outward flow duration of more than half second in the presence of a 3.5 mm perforator. Later on, it will be discussed that these are not sufficient reason to eliminate these perforating veins. Reflux should be evaluated in standing or reverse Trendelenburg position and with spectral Doppler study on long axis view and during Valsalva. There is another test called augmentation maneuver, which is used for evaluating reflux, and like Valsalva, it should be done in standing position. For distal augmentation maneuver, the augmentation should be gradual, prolonged, and followed by fast release and squeeze directly the bulk of muscle. Valsalva is acceptable for proximal parts of groin, such as common femoral vein, deep femoral vein, and saphenofemoral junction, while distal augmentation maneuver is okay for mid to distal part of superficial femoral vein. For scanning below the knee, it is possible for the patient to be seated with legs down. To perform a correct Valsalva, one should maintain it for at least 2 to 3 seconds and it should be sustained. A simulated Valsalva can be done in patients who cannot perform Valsalva correctly. For simulated Valsalva, ask the patient to take a deep breath and hold. And after that, the sonographer or the assistant pushes the patient's abdomen with back support. In some patients with a lot of edema or severe skin damage, the veins in the calf and ankle are best tested by active dorsal or plantar flexion and not augmentation. Augmentation of the ankle or foot is not so effective because little venous flow is found in these locations. A systematic evaluation for variceal veins consists of these areas. Longitudinal duplex color and spectral Doppler image of the common femoral vein, upper femoral vein, lower femoral vein, and popliteal vein, which are obtained by provocative maneuvers. Subsequently, for the great saphenous vein, longitudinal duplex and transverse great scale images of the saphenofemoral junction, mid-thigh, lower thigh, and calf are obtained. For evaluation of the small saphenous vein, longitudinal duplex and transverse grayscale images at the saphenopopliteal junction and mid-calf are obtained. Distal calf small saphenous vein imaging is indicated when stasis ulcer is present. Also, venous anteroposterior diameter should be assessed at proximal and distal great saphenous vein and proximal part of small saphenous vein in standing position. Note that in thigh and upper calf, great saphenous vein is usually found in a well-formed facial envelope called the saphenous eye or Egyptian eye, which is well defined in transverse axis. This is an important finding to recognize because escape of the vein from this envelope to a superficial location which defines as superficialization may change the treatment strategy. Let's talk about some pitfalls in sonography. Notice to some variations may be present in lower extremity anatomy veins and especially duplicated deep veins. In some instances, reflux may be present only in one branch. During sonography, wall thickening, fibrous band, and wall irregularities should be noted. This guideline emphasizes that in symptomatic patients with telangiectasia or reticular veins defined as CEAP class C1, ultrasound evaluation of lower extremity veins should not be routinely performed because it may result in unnecessary saphenous vein ablation. In symptomatic CAP class C1 patients with bleeding or severe symptoms of pain or presence of moderate to severe telangiectasia or reticular veins, ultrasound evaluation may be performed to exclude associated venous incompetence. However, saphenous ablation for C1 disease without bleeding is rarely required. In symptomatic patients with varicose vein defined as CAP class C2, the deep venous system should be routinely evaluated for infrainguinal obstruction or any valvular incompetence. This deep venous pathology, including reflux or obstruction, may affect outcomes and complications after intervention for superficial incompetence. In patients with mid-thigh or vulvar varicosis, evaluation for pelvic venous pathologies with ultrasound or other imaging studies is not indicated in the absence of symptomatic pelvic venous disease. Even in patients with pelvic variceal veins, which are asymptomatic, current consensus of experts supports the strategy of direct treatment for pelvic origin varicose veins using liquid, foil, phlebectomy, or ligations without the need for pelvic vein embolization. In the next part of the guideline, we will focus on the rational and scientific evidence for prevention and management of varicose veins with compression, medication, and nutritional supplements, as well as treatment options for varicose veins.